Chest examination inspection.
What seems to be the problem today?
I seem to be short of breath lately.
The inspection of the patient is an ongoing observation process that begins with the history and continues throughout the patient interview, taking of vital signs, and physical examination. The inspection is a series of observations to gather clinical manifestations, signs, and symptoms that are directly or indirectly related to the patient's respiratory status.
Okay, take a deep breath for me. Let it out. Very good. Palpation is the process of touching the patient's chest to evaluate the symmetry of chest expansion, the position of the trachea, skin temperature, muscle tone, areas of tenderness, lumps, depressions, and tactile and vocal fremitus. When palpating the chest, the clinician may use the heel or ulnar side of the hand, the palms or the fingertips. Both the anterior and posterior chest should be palpated from side to side in an orderly fashion. From the aphyses of the chest down. To evaluate the position of the trachea, the examiner places an index finger from the sternal notch and gently moves it from side to side. The trachea should be in the midline directly above the sternal notch.
The symmetry of chest expansion is evaluated by lightly placing each hand over the patient's posterior lateral chest so that the thumbs meet at the midline and about the T8 to T10 level. The patient is instructed to exhale slowly and completely and then to inhale deeply. As the patient is inhaling, the examiner evaluates the distance that each thumb moves from the midline. Vibrations that can be perceived by palpation over the chest are called tactile fremitus. The condition is commonly caused by gas flowing through thick secretions that are partially obstructing the large airways. Vibration that can be perceived by palpation or auscultation over the chest during phonation are called vocal fremitus. Having the patient repeat the phrase 99 or blue moon can often elicit vocal fremitus.
99.
99, 99, 99, 99, 99, 99, 99, 99. Percussion over the chest wall is performed to determine the size, borders, and consistency of air, liquid, or solid material in the underlying lung. When percussing the chest, the examiner firmly places the distal portion of the middle finger of the non-dominant hand between the ribs over the surface of the chest area to be examined. No other portion of the hand should touch the patient's chest. With the end of the middle finger of the dominant hand, the examiner quickly strikes the distal joint of the finger positioned on the chest wall and then quickly withdraws the tapping finger. The examiner should perform the chest percussion in an orderly fashion from top to bottom, comparing the sounds generated on both sides of the chest, both anteriorly and posteriorly.
Auscultation of the chest provides information about the heart, blood vessels, and air flowing in and out of the tracheobronchial tree and alveoli. A stethoscope is used to evaluate the frequency, intensity, duration, and quality of the sounds. During auscultation, the patient should ideally be in the upright position and instructed to breathe slowly and deeply through the mouth. The anterior and posterior chest should be auscultated in an orderly fashion from the apex to the base while comparing the right side of the chest with the left. When examining the posterior chest, the examiner should ask the patient to rotate the shoulders forward so that a greater surface area of the lungs can be auscultated.